Hello everyone, we are Team MediQvoice. Today, we present our project, an AI-powered medical speech-to-text assistant designed specifically for African healthcare. Our tool focuses on local languages like Swahili, Kikuyu, and many others. Why? Because while speech-to-text technology is already transforming healthcare in places like Europe and North America, African doctors and patients are still left behind. Our vision is simple: to help doctors spend less time writing and more time treating patients in the languages they actually use every day.
In African hospitals, doctors spend almost as much time writing notes as treating patients. With staff shortages, this means longer queues and less quality time with patients. We saw this challenge firsthand at the Deep Learning Indaba conference in Kigali, Rwanda, where most participants faced challenges in day-to-day interaction with locals, as the locals were more comfortable speaking Kinyarwanda than English or French. In Tanzania, Swahili is the national language and widely used in hospitals, yet existing transcription tools rarely support it. At home in Kenya, over 8 million people speak Kikuyu daily, including in medical settings, especially in rural areas where doctors and patients naturally communicate in their mother tongue. And this story repeats across the continent. From West Africa, where Hausa, Yoruba, and Igbo dominate, to Southern Africa, with Zulu and Shona, to North Africa, with Arabic and Amazigh. Unfortunately, current medical transcription models mostly exist in English or other non-African languages, leaving doctors without solutions in the languages they actually use with their patients. Globally, evidence is clear. Speech-to-text isn't just a convenience, it transforms healthcare. In emergency departments, reporting has been made up to 7 times faster, cutting delays that directly impact patient outcomes. At Massachusetts General Hospital in the US, adopting speech recognition saved more than $500,000 in just 2 years. It also helps reduce burnout, with studies showing documentation burdens cost $4.6 billion per year among physicians, and $1,600 per nurse annually. And in outpatient care, patient visits have been shortened from 9 minutes to just 3, freeing up doctors to see more patients. Our goal is to bring these same proven benefits into African hospitals, but in Swahili, Kikuyu, Yoruba, and other local languages where current tools fall short. Our solution is a multilingual AI assistant tailored for African healthcare. It listens as doctors speak in Swahili, Kikuyu, or English, and transcribes their notes instantly into structured medical records. At the core, we fine-tuned cutting-edge speech models like Whisper and Wave2Vec on medical data, so they don't just recognize the words, but also capture clinical accuracy. The assistant integrates directly into hospital electronic health record systems, reducing paperwork, cutting errors, and giving doctors more time to focus on patients rather than typing. In short, it's a bridge between advanced AI technology and the real languages doctors and patients actually use in Africa. What makes our solution unique is that it's the first medical speech-to-text system tailored specifically for African languages like Swahili and Kikuyu. We go beyond general-purpose transcription by embedding domain-specific medical vocabulary, so the system understands terms like hypertension or antiretroviral therapy as naturally as everyday speech. And because African hospitals often operate in low-resource settings with background noise, we've optimized the models to handle these real-world conditions. In short, the innovation is not just in using cutting-edge AI, but in redesigning it for African healthcare realities. For data, Swahili already has a strong foundation through Mozilla Common Voice. For Kikuyu, we will build a dataset in collaboration with local communities and healthcare partners. On top of this, we'll enrich both languages with medical terms through data augmentation, ensuring the models truly understand the clinical context. From a technology perspective, this is highly feasible. We're building on proven open-source models like Whisper and Wave2Vec, which already deliver state-of-the-art performance in speech recognition. Using Hugging Face pipelines, we fine-tune these models with African medical data so they can accurately capture both local languages and specialized medical terms. Our prototype will then be integrated directly into hospital systems, designed to run as a lightweight tool that works even in resource-limited environments. Here's the flow of our prototype. The doctor simply speaks in Swahili, Kikuyu, or English. The speech-to-text engine instantly transcribes the dictation, applies autocorrection using our built-in medical dictionary, and structures the text into the correct fields of the electronic health record. For example, if a doctor says, "Patient has pneumonia, prescribe amoxicillin," the system transcribes accurately, recognizes the medical term, and places it directly into the diagnosis and treatment sections of the EHR. The assistant also allows quick language switching, so a doctor can dictate in Kikuyu and seamlessly continue in English without losing accuracy.
Our targeted outcomes are clear. By cutting documentation time by 30 to 40%, doctors reclaim valuable hours to focus on patients. That translates directly into shorter wait times and smoother hospital workflows. What makes this unique is the language support: Swahili, Kikuyu, and beyond. So clinical care happens in the languages patients and doctors actually use. We're also planning real-world validation by partnering with local healthcare facilities, ensuring the tool is tested where it matters most. Ultimately, this creates a fairer system where competence, not language, defines opportunity, giving both doctors and patients the freedom to communicate naturally and effectively.
Ethics and privacy are at the heart of our solution. All patient speech data will be anonymized before use, ensuring no personal details are exposed. We are committed to meeting international standards like HIPAA and GDPR for healthcare security. We also recognize the diversity of African voices, different dialects, accents, and speaking speeds. To reduce bias, we will train and test our models on varied speech samples, so the system works fairly for everyone. In short, our design safeguards privacy, builds trust, and ensures inclusivity. Of course, challenges exist. Hospitals are noisy, so we'll use noise-robust models and filtering techniques to maintain accuracy. Doctors may hesitate to adopt new tools. That's why we'll involve them early in co-design and provide hands-on training to fit naturally into their workflow. Infrastructure is another real barrier. Internet and electricity can be unreliable. To solve this, our tool is offline first. It runs locally on a laptop or tablet, stores transcripts securely, and automatically syncs with the hospital's EHR once connectivity is restored. Finally, to bridge accuracy gaps, especially with medical terms, we'll integrate autocorrection and a medical dictionary. In short, challenges aren't barriers. They're design opportunities to ensure the system works in real African hospitals. Our strength is in our complementary skills. I'm Julius Maina, serving as the technical lead. I focus on model fine-tuning, system design, and integration with hospital workflows. My teammate, Edna Mugo, brings healthcare expertise. She leads data collection, validates the system against real medical use cases, and ensures the prototype fits smoothly into clinical practice. And we're guided by our mentor, Billy, who provides strategic direction and helps us align the project with real-world impact. Together, we bridge the gap between cutting-edge AI research and the realities of African healthcare, making sure our solution is both technically sound and medically relevant.
Our execution follows a clear 5-phase roadmap. Phase 1. Data sourcing and cleaning. We begin by gathering medical audio data in Swahili, Kikuyu, and English, then anonymizing and cleaning it to ensure both privacy and quality. Phase 2. Model fine-tuning. Using open-source models like Whisper and Wave2Vec, we fine-tune them on this medical data, adding specialized vocabulary and adapting to African accents and dialects. Phase 3. Prototype development. We will build a lightweight web app that doctors can use on a tablet or computer, with features like autocorrection and language switching. Phase 4. Testing and validation. Here we co-design with clinicians, gathering their feedback directly from hospital environments to ensure usability and accuracy under real-world conditions. Phase 5. Scaling and deployment. Finally, we scale the solution into hospital electronic health record systems and expand to other African languages. This phased plan keeps us focused, starting small but building toward hospital-ready deployment. Our project is designed to scale. After Swahili and Kikuyu, we can extend to other African languages such as Yoruba, Zulu, and Amharic, directly addressing linguistic diversity. By reducing documentation burdens across languages, we also reduce healthcare inequities, ensuring patients can be served in their mother tongue. Beyond healthcare, this work strengthens the African AI ecosystem, building local talent, tools, and datasets rooted in our realities. And looking ahead, we envision AI-assisted prescribing, where the system suggests treatments but doctors always validate, keeping patient care safe and effective. In this way, our project aligns with the spirit of Indaba, AI by Africans, for Africans.